Thank you.
Thank you, dear Enes. And dear colleagues, I will try to give you an answer whether substantial weight loss could be helpful in obesity-related conditions. So, as you know, the variety of obesity initial conditions are very wide, and everything is beginning with dysfunctional fat cells. And various comorbidities following obesity require practice guidelines for treatment. So, as you know, the therapy for diabetes concerning BMI is very different. For BMI between 25 and 26.9, we should recommend just behavioral therapy and diet and physical activity. And for those patients which have BMI over the 40, we should recommend it medications and also bariatric surgery. So, but what is the difference between obese diabetics and non-obese diabetics? In obese diabetics, we should add on metformin after the lifestyle change, and if it's failed, we should add on one more oral anti-diabetic. In non-obese, we should add on one more anti-diabetic. But in obese diabetics, we, in the case of failed of combination of metformin and one more anti-diabetes, we should shift the therapy from oral anti-diabetics to anti-obesity drugs. And this is a big difference. So the weight loss, about 10% in obese diabetics, improve glycemic control, but not just glycemic control, also improve or reduce cardiovascular risk. It is due to improved insulin sensitivity, changing gastrointestinal hormone secretion, and so on. So with bariatric surgery, we should resolve type 2 diabetes in 73%. And our patient with metabolic syndrome could be resolved in 90% after substantial weight loss after bariatric surgery. Mechanisms for obesity-induced hypertension are well known. But what are the recommendations for therapy? For stage 1 hypertension in obese people, we should not give them antihypertensive drugs. We should advise them changing lifestyle, weight loss. Then we should give them anti-obesity drugs. Eventually, if they fail this treatment, we should recommend bariatric surgery. But in stage 2, we should give them antihypertensive drugs. That is big differences between normal weight people and obese people with hypertension. And after the surgery, after the huge weight loss, more than 15%, weight reduction with anti-obesity drugs reduced number of antihypertensive drugs between 30% and 84%. So it's really helpful. And this is our experience after gastric bypass and weight loss between 35 and 40%, systolic and diastolic blood pressure in rest drop down, and also maximal systolic and diastolic blood pressure reduced. So after bariatric surgery, hypertension could be resolved in 63%. Increased cardiovascular risk in obesity requires to establish a strategy for early prevention of obesity-induced cardiovascular disease. And the first on this list is dyslipidemia. Dyslipidemia could be improved with medical as well with surgery treatment of obesity about 65%. So weight loss in dyslipidemia is really helpful. You know that obesity is disruptor of the female fertility, and the underlying mechanism is probably insulin resistance. And treatment of obesity with lifestyle intervention or with or without anti-obesity drugs and metformin could be really helpful, because that carries benefit of weight reduction, including improvement of pregnancy rates. So the reduction of weight just of 5% significantly improve level of free testosterone, LH, and insulin levels with improvement of ovulation rate. So polycystic ovary syndrome could be resolved in incredible 96% after bariatric surgery. Male obesity secondary hypogonadism, which is common state in extreme obesity in males, could be treated with weight reduction. And this study has shown that lifestyle change improved body composition and hormonal profile, represented by total testosterone, which increase after 6 months, and 17-beta estradiol decrease after 70 months with weight reduction of 10%. One more condition related with obesity is obstructive sleep apnea in adults, and the first treatment we should recommend it for those patients is weight reduction. After bariatric surgery, obstructive sleep apnea could resolve between 45 and 78%. And we have one more condition. It's non-alcoholic fatty liver disease, which it is definitely could be managed by weight loss. And it is very interesting that after bariatric surgery, fibrosis in non-alcoholic fatty liver disease could be resolved in 12% fibrosis. And inflammation could be resolved in 37%, and fat deposition in the hepatocyte could be resolved almost in 100%. So, what we can conclude? We can conclude that different stages of obesity-related comorbidities require different treatment. But weight reduction is the first step, and it is the main therapeutic approach in management of obesity-related conditions in all stages of obesity-related conditions. Thank you.